Good morning, everybody. Welcome to day three, day three of Douglas County budget hearings, July 8th, 2026. We are here to kick off the day with our emergency services. And so we've got, well, I'm just going to let everybody introduce themselves and kick it off with Brooke so that we don't double talk.
Thank you, Commissioner, and good morning. I'm very excited to introduce the emergency services departments here at Douglas County. First, I'd like to provide just a brief overview of each of these departments and their duties and functions inside Douglas County. I'll begin with emergency management. This department consists of 4 full-time staff members, 2 of whom are funded through a federal emergency management performance grant that is passed through the state of Kansas. This team coordinates the administration, planning, and execution of emergency management and preparedness plans and activities throughout Douglas County. They develop and implement disaster management plans designed to protect people and property during and after emergencies. Most recently, they have set up a unified command structure to prevent emergency or to prepare for emergency response related to World Cup events in Douglas County. The Emergency Communications Center operates with 36 full-time staff members. Currently, the department is down only 1 FTE and has maintained its staffing levels for the past year and a half. That's an impressive accomplishment given the demanding nature of the work that they do. By the end of 2025, turnover rates had dropped by 11.5% when compared to its peak in 2023. Just last month, the center successfully moved a live 911 operation to a new location without any interruption or loss in service. Also in 2025, our Emergency Communications Center staff handled 250,000 calls. Of those calls, 46,000 of them were 911 calls, and 99% of all calls were answered within 20 seconds. Emergency communicators serve on the front lines of emergency response and deliver an essential service to everyone living in Douglas County. And finally, Lawrence Douglas County Fire Medical, their team responds to all fire and medical calls dispatched within Douglas County. In 2025, LDCFM staff responded to 12,666 EMS calls, 176 fire calls, 1,513 false alarms, and 3,400 other calls for service. Of those responses, 54% of those required medic unit resources. Additionally, referrals and patient contacts through the Mobile Integrated Health Program increased by 44% when compared to 2024. Commissioners, in your budget book, you'll find a memo from LDCFM leadership outlining their budget request along with several supplemental requests. The highest priority of those is for a mobile integrated health team lead position. This role is needed to ensure that the MIH team can maintain consistent availability for patient care. Currently, the 2-person team must shut down whenever one paramedic is unavailable, limiting its ability to make patient contacts and meet referral demands. If approved, this team lead would provide frontline supervision, cover field duties when a paramedic is absent, and take on essential administrative and coordination responsibilities that are currently straining leadership capacity. In addition to that team lead position, LDCFM is also requesting a 3rd MIH paramedic. This addition would enhance the team's ability to respond to patients and build the staffing necessary to launch intermittent alternative response operations. Lastly, the 3rd supplemental request that you have before you today would be adding an EMS administrative specialist, which would expand the billing team. This position would support essential administrative and financial functions that indirectly strengthen the MIH program and overall EMS system sustainability. I'd like to take an opportunity now and turn the mic over to my emergency services staff members to introduce themselves. I'll start with Chief.
Good morning, everybody. My name is Joe Hardy, Acting Fire Chief here at LDCFM. Appreciate your time to give us this morning.
Good morning, Tyler White, Acting Deputy Chief at LDCFM.
Mackenzie Zell, Chief of Staff, LDCFM.
John Darling, Division Chief of EMS for LDCFM.
Good morning, Sonia Baeza, Deputy Director for Emergency Communications.
Tony Foster, Director of Emergency Communications.
Robert Benecki, Director of Emergency Management.
Thank you, Brooke. Welcome, everybody. Well, as outlined, we have a few supplemental requests from LDCFM and otherwise full budget materials for all departments. So who's got a question top of mind, commissioners? Go ahead, Commissioner Willie.
So I have quite a few, but they're all for LDCFM. So I don't know if use of time, if you want to ask if anybody has questions for the others first.
Point. Do we have any questions for Emergency Communications Center or Emergency Management Commissioners? Okay, well, LDCFM, spotlight's on you.
That's my cue. Thank you. So look, kind of lumping the first and second supplemental requests together, I just had a couple questions about generally how MIH works. And one of them was, you mentioned the IBSC community paramedic as a position. How's that different from a paramedic or from a technician paramedic, which is the other title you had in there?
Thank you for that question. I didn't know how deep into the weeds to get in the document, but I'd be happy to explain it. So IBSC is the International Board of Specialty Certifications, and community paramedic, you have to be a paramedic with experience, and then you go to this additional course, which I believe was 6 months. And the issue is, for most paramedics, our job is to take care of you for the 10 to 20 to 30 minutes it takes from the time we get to on scene to the time we get to the hospital. So it's emergency medicine focused. They don't do a whole lot with training us to deal with like lab values or wound care or chronic management of conditions or medication reconciliation or all of the many things that MIH technician does. So that process took about 6 months to get them through, and it's a very intensive course. In addition to just the class, there's a lot out of class, study time to really make sure that you're qualified to do this, which is also why we can't just simply slot one of our current paramedics into that position and expect them to function with nearly the same ability. Like, if you ask me how to interpret a lab value on blood gases, I don't have that information. Our MIH paramedics do. And that's just one example of what that means.
The technician paramedic, which is one of your requests, is that just a regular paramedic that's not operating at that community paramedic level, or is that something else?
Sorry, the two requests we had on the MIH team, one was for a team leader that would be a IBSC certified paramedic who would also provide that frontline supervision. So that was one position. The second one was for an additional MIH paramedic. So that would be a third MIH paramedic if we got both of those.
Okay. So the designation of MIH technician slash paramedic was just that they'd be in the field, not necessarily a lead. Is the differentiation? Yes.
And to be clear, the expectation of the team lead is they would also be in the field probably about 50% of the time.
So it's kind of leading me to like, what are the skills that are really needed in MIH? And that actually gets me, because community paramedicine is different from paramedicine. Are there other skill sets besides that level of care that could co-respond, or that's probably not the right word, but fulfill that third position that's not trained to that same level? Like, can an EMT serve as the third person in that role so that they're always responding with a certified community paramedic?
So the answer is potentially, but there would be a decrease in the ability of service and the throughput. So when we're able to deploy 2 community paramedics to a patient's house, they can operate in parallel. One can be doing medication reconciliation while the other is doing wound care. So while we might be able to send a second person to be with them and have that sort of buddy system, they wouldn't be able to provide the same level of service and the same efficiency. So while we might still be able to get the team out in the field, first of all, we don't have that extra person. We would have to pull them from one of our existing staffed units and then shut down like an ambulance or fire apparatus, which is not optimal. And second of all, that would be getting a lower quality and they wouldn't be as interchangeable. The idea with what we have right now is we can kind of swap them out. So if we got both of those positions, you would have 4 community paramedics that would be able to provide these services, and we'd be able to divide them in multiple different ways to get the team. With a lower certification level, we would sort of lock into one deployment model, and then if one of those people is gone, all of a sudden the team shuts down, where we wouldn't under our current proposed model.
So I noticed with both of those supplementals, the first one and the second one, they both include a vehicle. They each include a vehicle, so like the team lead also had a vehicle there. Was that part of your intention?
So, yes and no. So we would need a staff vehicle for the team lead because that would just be the baseline vehicle like what I drive, which doesn't have it has lights on, but doesn't have all of the equipment. So one of those was for the vehicle. The other one was for all the equipment that we would have to actually stand up a second team. So that's, our cardiac monitor, our bags, our portable equipment, all the other stuff, which ends up being about the same cost as the vehicle by the time you get done adding it up. So I believe that's how it was supposed to be set up.
I can take a look at that too, and other people are asking questions.
So yes, it's vehicle modifications for the second MIH vehicle is how it's characterized under the second the high priority mobile integrated health technician paramedic. So that's not the vehicle. That's the assumption we have that vehicle.
And Commissioner Willie, a lot of our work, our members are going out to the residences, or that's where a lot of their work is out in the field. And so, if we have only one vehicle, it would prioritize, one incident occurring. When we have multiple, we could disperse more out there to see more people, hopefully.
Looking like, so with the 2 responders, it's been 57% average of the time can be actually on calls versus either doing admin things or things where there aren't 2 people, so they can't be out in the field. The 3 responders might get that to 80%. And that was one of my questions with is that just now a 3-person team? And is there another vehicle needed or not? And you're saying that's just a staff vehicle, not necessarily a vehicle that responds.
Right. What that would do is allow us to increase our uptime. So basically, we would still have if we have the team lead by itself, we would still need a staff vehicle because that person would be going to meetings and attending things they need a way to get from point A to point B, just like I have and the other staff does. But that wouldn't be a fully outfitted response vehicle where it has the cardiac monitor, the auto pulse, all the other things. So that would increase the reliability of that first team. Adding that additional 3rd MIH paramedic, 4th member of the team overall would, when all 4 of them are there, allow us to stand up 2 teams that would operate in parallel, which would allow us to really start getting data about effectiveness of things like alternative response, because we aren't really able to stand up an alternative response based on the demand just from our referrals right now.
And so that alternative response, I'm really curious about that. I think that there's a lot of capacity to learn in that space. And I think there's, a few organizations across the state that are trying to dabble in that. I think it's a good space for us. The 4 responders, then it looks like it is predicted maybe not to get to 100% of response time, but 90% or so. That's with the new vehicle that would also respond. But the bonus there is the ability to do some alternative EMS response. Can you talk to me about what kinds of calls would fall under that and how would dispatch?
Yeah, absolutely. And this has been something that I've been talking about with Sonia and dispatch a little bit. It's just we don't right now have really the capacity because their days are, with the 2 paramedics that we have, like we said, they're really only available about 50% of their scheduled 40-hour work week. And by the way, that's presently when they're only using about a quarter of the leave that they're accruing. So if we continue to move forward, I would expect their reliability to go down. Otherwise, they're losing benefit time, which is not a thing we want our employees to be doing. So what that would look like is when we had the ability to have two teams operational, we would put a unit on duty with dispatch. We would work with dispatch to identify specific call types call determinant codes. Is that
Either in nature or
Yeah,
determinant.
nature or determinant code based on their emergency medical dispatching algorithm. And we'd say, okay, when we have this second alternative response MIH team, these call types, these determinant codes, we would then send the mobile integrated health team as the primary response, initial response, rather than, a fire apparatus ambulance. And the benefit of that is that right now our current model is someone's having problems, they call for a complaint, one of our normal emergency response crews goes out, sees that this person has deeper underlying problems, fills out a referral, then our mobile integrated health team or some of the other teams they partner with will go out and make contact. But, that can be 2-3 days after the fact, potentially. Also, it relies on, hey, we're triggering that, hey, this is a person that's having problems. So it's a lot more reactive. What we find is that most of the people who do require mobile integrated health services, they're not calling for heart attacks. They're not calling for like major injuries. They're calling for kind of low acuity complaints. And if we can get specially trained IBSC certified paramedics in the door that much faster, we can ideally decrease the amount of time it helps to get them directed to the appropriate resource. And I think that if you look at how emergency services have evolved, we're always going to need the capacity to take people to the hospital in an ambulance. A lot of the calls that we get for 911 don't necessarily require going lights and sirens to the hospital. And in fact, the hospital is not really the most appropriate way to care for them. And so if we have the ability to kind of put our toe in the water and kind of determine the efficacy of that program, we can validate if that's something we want to move forward, because this would be a pilot program that would be available when we had staff. It wouldn't be something we stood up 24/7. And before we wanted to try to talk about standing up something 24/7, we'd really want to validate how well does it work in our community. Hey, we had it, 40 hours last month. Of those 40 hours, we responded to this many calls that diverted an ambulance, and therefore we can predict that if we stood up more, we'd be able to do that. This would be how we'd kind of get that data, rather than just saying, well, we saw something work in this community, we hope it works here.
Thank you.
Most recently, we heard from Familiar Faces and Lawrence Memorial Hospital, and they told us that they work a list of about 154, and every Monday they meet with a team and they discuss a list of 25 that they really want to lean into and support, because they are some of our highest utilizers that are also calling dispatch. And so as you seek to potentially roll out this pilot and address maybe some of those higher utilizers, are you potentially going to be partnering with this group that's meeting on a regular basis and seeking to maybe triage that particular list and support some of those higher utilizers that we know are on the list of 154 potentially?
Yeah, absolutely. So currently our MIH, we have a member of the MIH team that is in every Familiar Faces meeting. And so we are intimately involved with that because, yes, those patients, in addition to frequently being at the hospital, frequently being in jail, frequently being in other parts of the social safety net, also frequently involve EMS. The downside to having it under our current staffing model is that time that we spend in Familiar Faces meeting, the MIH team can't roll out and actually respond to people. The benefit of having, for example, the team lead was we could participate in that meeting with the team lead while still maintaining uptime for the team to be out responding to people. So that's the benefit of why we would like to have additional resources for that. But yes, that would definitely be something we'd be involved in. I do want to manage expectations, though, because those are complex cases, and it's not something that MIH alone is going to fix. What our goal with this is that we're also helping people prevent getting to the point they're the high utilizers. And that's where I think we see a lot of benefit, because while there are going to be people who have very complex medical cases, there's also a lot of people who we have the ability to intervene early and prevent from getting there. And when we look at our data, for instance, we've seen that like the number of times an unhoused person contacts EMS per quarter has dropped significantly over the past 4 or 5 years, commensurate with the application of resources, not just MIH, but the entire community. But what we see now is about the average time a patient who is unhoused contacts EMS is very close to the rate at which the housed population does. So we're really being effective at helping to intervene and reduce unnecessary repeat usage of the EMS system. And that's something I see us continuing to do with additional resources.
Okay, great. So it's great to know that you do already have an MIH support individual that's in those meetings, because we did hear that the individuals that they are seeking to support do have high acuity behavioral health needs. And so this ask is in our behavioral health bucket. Is there another meeting that you all are in where you are looking at individuals that do have behavioral health needs, mental health needs, social, I already know that you do look at, you already have a list too, but is there another meeting where you are convening and taking a look at other sectors of the population?
Yes. So the mobile integrated health team, I think was it last year or early this year, we came and talked about the 3 teams model.
Yes.
Where we work with the Project Lively, we work with the health department and ourselves as a 3-person team. And we're also in the process of getting other teams that can kind of collaborate with us where we meet every Monday with that group to talk about all of the referral forms and find out, because most of the people that end up in the MIH realm, they don't just have medical needs. There's also social needs. There's also other, potential behavioral health needs. There's lots of other needs. And so we can't function in a silo. We have to function multidisciplinary. And so that's where we have that group that meets on a Monday. And then they have that SharePoint group where throughout the week, they're corresponding and updating the status of individuals' cases that they're working on that are collaborative. And that way we can also monitor and figure out, hey, this person got referred. We haven't had a chance to get eyes on them. Can, the health department make contact? Can Project Lively potentially make contact? We work together same way. If the Project Lively can't reach someone, we can go out and knock doors and maybe we can get a hold of them. So we all work together on that on an ongoing basis. In addition, we're part of the Crisis Services Operations Team, CSOT, and the Douglas County Crisis Response Team that I'm currently in as well, where we're trying to do not just on individual cases, but structural improvements and structural things. Like one of the things that we've worked on over the past year is really refining how LDCFM and TRC work together to make sure that patients get to the right place at the right time. So that's just one example.
And then for your referrals, do you have case closure and or follow-up benchmarks that you're taking a look at and or seeking to hit? So when I think about like food, or transportation, if someone has a particular need and they need to get to a particular appointment, maybe it's a sedation procedure and they don't have any support. Do you have particular benchmarks that you're looking to hit?
Well, yes and no. So the answer to that is typically MIH is not what counts as case closure as much as case referral. So we're not typically the long-term solution for folks. So what we do is we refer them to the more appropriate we basically step in, fill the gap, and then get them to that. So typically at the time that they go off of our active cases, their needs have not closed. They've just been adequately referred. And we do monitor hey, we've seen this person. We don't erase their record. They go on an active status. Then if we run them again through EMS or some other contact, we will have that backstory that we can go back on and address and have the knowledge of, hey, here's what's happened before. And that's been very helpful when someone who maybe we stepped in as a high utilizer a year ago, we got them to a more stable place. Now they're back in crisis. We're not starting from square one. We have all of that backstory, all of that documentation, and not just for ourselves, contact with all of hey, this is their case manager with this group. This is the person that's worked with there. This is who we talked to at APS. So everybody has comprehensive knowledge of what's going on with those patients.
So then do we have a community partner that is tracking that case closure so that we do know if that individual has been helped in the end? So when it comes to transportation or food, whatever that particular need was that you referred them for?
So I think that typically, because it's not a single group that we're referring to, it has sort of been
attempting to build an integrated system, right?
So I would say that there's work that we can be done there. I know we've talked about better technological tools, which might help track some of that stuff. And we don't really have the bandwidth right now to say, oh, I'm just going to pick up and call every single person. Because we also, a lot of our MIH patients, we see once because it's a short-term need that we then get them to the right resource. So if you look at our, demand curve or whatever, it's not a bell curve. It's more we have a bimodal distribution where there's a bunch of people we see once or twice, then it tapers off. Then we have our more complex cases we see for a longer period of time. And so especially those people that we are able to effectively intervene with very quickly, that's a large number of people. We don't currently have the bandwidth to do rate checking. That's something we've talked about. And, I don't want to promise anything, but my hope would be with additional staff, we would be able to go into that road.
Yeah.
It's just right now we're at capacity.
Yep, I understand. That's why the request is before us today. Yep. Okay, thank you.
Question. Oh, go ahead.
So I've been really impressed over the last few years with the focus on data and sort of looking at specific calls. And
My guess is that you wouldn't be asking for this if you didn't feel confident that the data is telling you that it's, I think, and when you came with the 3-team approach, you actually showed a decline in the number of ambulance calls we're seeing for the very first time. I didn't hear you relate that directly to MIH, but maybe it is. I'm interested in you talking about a little bit about what the data is telling you about MIH and why you think this would be a good path to expand services.
Absolutely. And part of that is I can talk about correlation. I get a little nervous about talking causation. Also, I want to be very cognizant of the fact that MIH doesn't operate alone. We have a number of community partner groups that we work with. So standing up and saying we alone are responsible for this is not really fair to all of our partner groups that are also putting an enormous amount of work and time and effort into this. But so if we want to talk about maybe the comprehensive community efforts, which include MIH, I would say that we've done a couple of things recently that have really helped reduce ambulance calls. One that isn't directly pertinent to this is the non-emergency transfers that were approved last year. That's been probably a third to half of our total reduction, but the other half is we actually are seeing a decrease in demand. I don't have the exact numbers in front of me, but while I can't definitively point to that, I can say that it is more than likely driven by the fact that we are not seeing as many people calling. So for instance, I ran some numbers like look back in, I think it was 2021, the average, if we saw a person once in a quarter, if they were housed, we would see them an average of 1.5 more times that same quarter. If they were unhoused, we would see them an average of 3 times in a quarter. That number is now 1.5, sorry, it's now 1.5 total calls per quarter per unique patient. So that's for the housed population and 1.75 for the unhoused population. So they're very close together, and that's a over 50% decrease in prior utilization. So what we're seeing is we don't have nearly as many repeat usage of the same individuals of EMS services within a given quarter as we used to 5 years ago. I would say that the efforts that we're doing here to kind of do that outreach, get people connected to better resource, has happened. That's on the data side. On the anecdote side, I can also tell you that every time I talk to any of our crews, they say, hey, this has been a very effective means of helping us get these people that we see that we don't know how to help, get them the help that they need. And so that's been something that I've been very proud of to be a part of.
So that picks up on the last thing you said there is picking up on my next question. So crews are telling you that they are very much, they can see an impact, and it may be anecdotal, but that's what they're reporting. This request is for completely 100% it being funded by Douglas County, and yet you just said that the impact was on the entire fire service. Can you give me your rationale on why it's not that split between Douglas County and the city that we've traditionally done?
Well, so as this was originally established, it was funded through DCEMS. We are currently in the process of working through a new shared expense and EMS agreement. And I believe that that's something that can be discussed in that process. Right now, I'm moving forward with it as it has been. Were the revised EMS agreement to move them from the DCEMS bucket to the shared bucket, that would be a thing that would take place. I just can't really propose that myself in this process. What I would say is that I want to be a little careful about pretending that, or not pretending, but just positioning it that this is something that directly impacts just the fire crews for LDCFM. We have been really aggressively trying to get the information out to our county departments as well to do outreach there. Now, it's true that, I think it's like 15 out of every 16 EMS calls in the county happen within the city limits because that's where the majority of our population is. That's where the majority of our demand is. But proportionately, there's a lot of work that can be done for outreach in the rural communities as well. And that's where we've done a number of initiatives trying to, kind of close that reporting gap. So that includes trying to deploy QR codes to all the county agencies to make sure that they can refer. Also, we're in the process of trying to get the county agencies better patient care reporting software, because one of the benefits we have with LDCFM patients is we have a longitudinal record we can track. We don't really have that if it's just a county response right now, and we'd like to get that so we have that same granular data. So those are a couple of reasons. The other thing I would say is that while it's true that we do use LDCFM fire trucks to respond to medical emergencies, and therefore, by reducing medical emergencies, it also reduces fire truck commitment. We also use ambulances to respond to fires. And one could very easily make the argument that if MIH should be a shared expense, so should the LDCFM prevention budget, which is a much bigger picture conversation than I can really address at this forum.
I'll carry on with the billing conversation if that's okay.
Yeah.
Currently for EMS calls, really they're only billed for the patient is only billed if there's transport. Is that right? Are there any billing opportunities that come with MIH?
So a couple of clarifications. One, we do have the ability to bill for an ALS treatment, no transport option right now. So like if we show up and we provide dextrose for someone who's diabetic, we can bill for that. The problem is most insurance doesn't pay for that because the lens that most compensation is done for is as EMS as a transporting service. And we intentionally decreased the price on that to $100 because we weren't trying to basically take advantage of vulnerable people while still recouping some of our cost. There has been talk at the state level about being able to bill for BLS treatment, no transport, where maybe we're not providing an ALS skill set, but things like that. And there's also many other states have expanded to include MIH as a billable expense. Kansas is in the process of working through that. And we have been talking in the governance level a lot about like, hey, if and when that happens, we would want to be able to adjust our fees. The benefit of the recent code change that was made by the county and city commissions last year is that once that happens, we don't have to anymore go through a separate vote by both commissions to change our rates. Even both commissions have delegated to the city manager and county administrator the ability to authorize rate changes. So when that were to happen and make it a billable expense, we can move on that effectively and efficiently.
We talked a little bit about, can any of this fall under the Douglas County, City of Lawrence split? And I'm thinking especially around the admin portion of it, just thinking that, as it does help the whole organizations. I know that's a larger conversation than what we're going to have right now. The other thought was, especially around alternative response that is intentionally decreasing transportation to LMH and other hospitals, so primarily LMH. Have they been a part of any conversation about community paramedicine and how it benefits them? And if they'd like to help fund a pilot program that got us to the point of finding out more about what alternative response could be?
So I know LMH has had a change in leadership fairly recently, and that is something that the new CEO did some work on in the previous thing. I've been in contact with one of their VPs as we try to work through several issues like that. They're also having some other staffing issues that have kind of prevented us being able to get together, but that is a conversation I would love to have because I do think it has a lot of benefit for the community hospital.
And kind of the last one is community paramedicine overall. I think probably at least in my mind, feels like a pretty good fit for some of the rural health opportunity grants.
Yeah.
But of course, that's the rural portion of it. I don't know if that would also count within the City of Lawrence, but is that a conversation that could be had for offsetting any portion of costs that might go into these supplemental requests?
So I know one of our issues has been like staffing with grants can be challenging because, then what happens when the grant runs out? And also just the staff time to pursue grants. We have not had a lot because we've been had a lot of staffing shortages at the admin level just within LDCFM. So while I wouldn't at all be opposed to anything that would help us, shore up our system, I would be a little concerned about, hey, we're going to start a program where we're going to hire someone with the potential that in 2 years they may no longer be here. That's hard to get people, especially who work in emergency services, who are used to, hey, this job will be here as long as you're here, to jump ship for something that may not exist in 2 or 3 years. And I would have concerns, especially because we wouldn't want to recruit brand new medics for this. We really want people who've been on the streets for 5-10 years, got some experience, used to talking to people, that having that person who's usually typically invested in some sort of like CAPER system say, okay, I'll take an opportunity that may not be there. I mean, it's possible. I just would, when we talk about recruiting, that would also potentially affect that, is saying, hey, we don't know if this is permanent.
LDCFM is open to grant opportunities. So if that is something that we're encouraged to look into and apply for, then that can be discussed in our governance meeting.
Hey, thanks.
Other questions, commissioners? My questions have been asked. Thanks.
I got a question about your third proposal for a billing assistant. I presume you think that position can pay for itself?
Yes, with an asterisk. So the issue is that's not something, there are not a lot of people who, code billing for ambulances. So it's not like there's a deep talent pool. Typically, we would hire that as a new hire and train them, and that process takes a year. So by the end of the first year, I would expect an increase in efficiency that would offset, I think I did the math where it was like 1%. Yeah, 1.6% increase in our revenue recovery would cover the cost of that. And I believe there's probably at least 5 to 10% room for improvement on what we're currently recovering based on some of the other agencies nearby and industry standards. But so it wouldn't be immediate. It would be an investment. The other thing, and where I started out thinking this was, hey, it would be nice to have if we wanted to continue to, increase revenue. A lot of the payers are making, claims collection more and more time consuming. And so if it takes more time for this to recover the same amount of money, and we only have certain staff time, not next year, but some point 2, 3, 4 years down the road, I don't have a magic crystal ball to know when, I see our current staffing being inadequate to maintain current revenue unless something changes, because things that used to take, 5 minutes now take 10 minutes. Things that used to take 10 minutes now take half an hour. And so when our goal is to, maximize billing recovery, what ends up happening, unfortunately, is we reward that behavior by triaging the lowest hanging fruit first. And then the stuff that takes more time, we may not have time to pursue appeals at the end, not because we're not doing the money, but because that would just mean that we're collecting, $5 here means that we forego the chance to collect $15 over here, for example. So that's where I see that as something that ultimately will be the commission's decision of like how much revenue we want to generate. But right now, I think we're okay. We're doing good this year. We are on pace to exceed revenue again this year. I think we'd probably be okay next year too, but at some point we would be in that situation. And my concern is because it takes at least a year to get somebody trained up. If we do have a year, if we wait till a year where we are seeing our revenue actually go down, it's going to take another year before we can really be at a point to pull ourselves out. Does that make sense?
I guess I'd like to add on too, in my experience working with the LDCFM budget and ambulance collections, I've not always seen that to be the case. So sometimes when we've added positions, we've not gone up in revenue commensurately. So I would want real clear direction from the commission that if the intent is that this position pay for itself, then what happens if it doesn't? So, I mean, we've had some pitfalls in the past with collections, and they haven't been about necessarily or having a vacancy. So I just think it's important to sort of offer that alternative perspective.
And within this kind of peaks and valleys, it feels like we've been on a good trajectory with billing for revenue and being able to offset some of the changes we've made. So, it certainly, it has been uneven, but it seems like it's been in the right track. Would you want to respond to that?
Well, and I guess I want to say too, like if you want us to increase the revenue by $75,000 to cover the position, that's the kind of direction I would need. Is if you're saying it'll pay for itself, are we increasing the revenue by $75,000?
But we wouldn't see that. I think what I heard John say was that we wouldn't probably see that for over a year because it would be delayed as that person gets online. Is that right? Am I correct in my understanding that?
That's what I would feel. I would not feel comfortable saying the first year it would 100% pay for itself. I was imagine that as they get trained on, they can take on some responsibilities, but I would think by the end of the first year, they would be at the point where we would get enough efficiency gains to offset the cost, but that benefit may not show up until the second year, if that makes sense.
Doesn't make the decision easier, but it makes sense.
Yeah, I guess if there's any revenue that might occur within the year of 2027 that would help offset the 75,000 requested, I think that would be an important piece for us to know as we go into deliberations.
I have aspirations that the state would authorize certain things, but I can't tell you definitively that when, like, for example, billing for MIH would come online. We also have the ability to change ambulance rates. There's also a responsibility of we're not trying to make money off of vulnerable people. So that's the dynamic we're in. And so we really try to look at where we are in the market and not charge excessively. So.
Do you have any problems or foresee any issues with whatever software you use to invoice or seek reimbursement from?
I would say that having been through a couple since my revenue cycle manager has been in her position for 30 years, she would probably tell you there is no one perfect piece of software. We have current software that is very good at helping us track down second, third payers and get additional revenue from that way. It does have some complications that our previous software didn't. So it's sort of a trade-off situation. I don't currently foresee a need for us to change anything with our billing software. The real issue is that it's the staff hours needed to pursue claims to being completed, which that's just the nature of health insurance these days.
Commissioners, I'd like to go back to emergency communications, but it's going to be sort of roundabout here. So you've been asked to become a point person, a point department for redirecting services to the right place. That seems like a whole lot more responsibility, a whole lot more expectations on your department, and yet you've held the budget at the same level without supplementals. Can you share with us how you did that?
Greatly. A lot of it is about efficiencies, finding out how we can do more with less, and be able to bring new processes online, but still use our same workflows. So that way we're not having to add additional workflows, but we're actually using our current workflows to be able to just augment the process, is one piece. Now, I would say that, that's the last 3 years. Going forward, at some point, we're going to get to a point where we're going to have to probably add an additional person into that workflow. But at this point in time, we're still level with our expectations of our staff. But a lot of it is just finding efficiencies within our workflows to make sure that we're not overworking our staff, and we're not underperforming for our services.
Thanks. I wanted to highlight that and then give other partners around the table an opportunity to talk about. I mean, is there opportunities as we think about expanding services to see a reduction of costs down the line? I'll just leave it there and see if there's a response to that.
Commissioner, I don't know if this is really going to answer your question, but we have been very intentional over the past year working with our partners at ECC and internally to what we would call right-size response to match risk. The county ultimately purchased the equivalent of emergency medical dispatching for the fire side, and we've worked really diligently to look at how we're deploying and saying, are we deploying in the most effective and efficient way? We often hear, why do you send an ambulance or a fire truck to every medical call? Well, we looked at our numbers and the answer is we don't, but we also are fine tuning that even more. And part of that is also with, like John mentioned, the alternative response piece. We have a lot of call types that don't even require an ambulance ultimately. And so how can we work to get MIH there? So I think we are doing a lot of work internally to try to become more efficient. It's been clunky. We're 7 months in, and we're still looking at how it's playing out. And we're going to continue to do that work through the rest of this year and into next year to make sure that we are effectively sending resources to the appropriate calls.
I would like to also echo your kudos to the ECC. They actually invited members of first responding groups in Douglas County to come attend their training when they were onboarding that. And we were able to provide feedback and recommendations so that it would actually fit Douglas County and not just kind of a plug and play.
Yeah, and I think I also can't say enough good things about EM and the ECC and all the good work that they're doing in our community. And I think that what you see is where we're trying to go is the idea that we would ultimately be in a place where we were, like we said, right-sizing that. We just don't have the people to do that right-sized response. And part of the other concern is it's not just about, hey, we don't want to use an ambulance because, we want to reduce ambulance calls, just because we're keeping that ambulance available for those more acute emergencies, rather than when somebody does have a critical emergency, the ambulance that would normally be in their district is taking care of something that probably could be handled by that team. So those are the qualitative efficiencies rather than cost efficiencies that we're pursuing. And in the same thing with like the revenue generation, trying to put it on the radar of like at some point, the same number of people are probably not going to be able to. So it may be an investment the county wants to pursue in terms of like ensuring revenue generation capacity does not get affected.
It sounds like you think ahead a lot, and like what should it look like in the future? How might we right size it? I'd love to hear your thoughts on when we start to move staff from what their current position is to a position that may be more effective, more efficient, rather than continuing to add staff. Do you have thoughts on that?
I'll speak a little bit to that. One thing that we've seen in the last few years is specifically within training our first responders on those fire trucks and medic units to start thinking about their response and care for patients and bystanders and all of the risk items that come into incidents, and be more holistic with that approach versus what I just say, like the Band-Aid approach. You call the heroes show up, they put a Band-Aid, we leave, but like problem is still there. And it's very cyclical. Specifically, the example that I'm thinking of is the training that was put on in the last year about working with people with autism and how responders and actually connection with dispatch of information that's collected, and how when we show up to a home with someone that has autism, how we can respond instead of just causing potentially more harm than what we were originally called for.
Commissioner Kelly, I like to also add, I appreciate the acknowledgement of forward-looking, like adapting for future and looking at other alternative responses. And I think that's where that MIH looks at, where we can start putting value into the people that we see that are actually taking the call volume away from the most expensive piece of apparatus that we have on the truck out on the streets, with our fire trucks and our ambulances. And so looking at that, but also looking at what we're all dealing with is like when we take an engine out of service, we have to look at all of our deployment models and adapt. So we're adapting here, but we're also trying to look and see what we can do to do that forward thinking too. So appreciate the acknowledgement of that. And working with our partners has been really, I can guarantee you they were probably frustrated with us many times over this past few months, looking at the process, and our members have been too, but we've been able to stay focused on the end goal. And that's what makes our partners so important, to be able to work with them and have that relationship here, because it all falls down on the ones that are actually doing the work, So thank you.
And I will add one last thing. We are trying to find ways with our existing staff to support MIH. For example, there are two-person teams. So if one of them calls in sick or is unavailable that day, but there is a critical need that the remaining on-duty MIH employee needs to take care of that day, we will send, and we have sent within the past 2 weeks, an ambulance to go support that MIH employee, more so for their safety. We have some contacts that MIH makes that we would not feel comfortable sending a single employee to. So we, work with our on-duty battalion chiefs and our on-duty crews to take that ambulance out of service to go support our MIH team. And, it doesn't happen frequently, but it is something that we will continue to do. There is a downside. We're taking an emergency resource off the streets, but the work that MIH is doing is equally as important, and we want to continue to support them.
Just point out that support in the rural area comes from BLS response, and then that response in the urban area is coming from an advanced ALS response with transport capabilities. So just kind of keeping in mind, like what is that backup need? Is it an ambulance, or is it something else we should be looking at in the community that's maybe not trained at the paramedic level that'd be cheaper?
Yeah, so that in that particular case, it was happen to be within city limits. So that's why we send a city apparatus. Had it been the county, we would have done the same thing. We could have requested a county unit, but a lot of times too, those are, volunteers are asking to walk away from something for it. In this particular case, it was a scheduled infusion, but a person that needed it every single day. So we couldn't just cut it off. More holistically too, and also I want to manage expectations. I don't foresee a situation where someday we take an existing fire station and turn that ambulance into an MIH crew, because you're going to have time deployment at all times. What I do see is that as we have MIH teams, if we're able to expand emergency response, we go from a situation where, well, we have a fire station with an ambulance in it, that ambulance is out 50, 60% of the time. So the actual reliability is not there. Now we're taking care of some of those low acuity calls at MIH. So the reliability goes up significantly for that stage unit, because we're trying to solve two problems. One is like time critical response. The other is basically, efficient use of resources. And so there's kind of two different things at play. Does that kind of make sense? I don't want to create the impression of, oh, if we do this, eventually we just won't need ambulances or anything like that.
So as you can see in our proposed budget, with the proposed city manager's budget, it included expansion for Station 6. Within our enhancement request, LDCFM focused on risk reduction in all fields. So EMS is specifically what we've talked about today. On the fire side, we were recommending bolstering that group as well. So focusing on not necessarily redoing how we're thinking fire trucks and medical units are responding, though it is touched on in that new deployment matrix, but focusing on the success and risk reduction and moving that way.
Maybe it would be good for you to give us a little update on the expansion that the county helped support for this year on the new ambulance and how that's going and plans for Station 6.
I will speak just from an operations perspective. And I know this was communicated towards the end of last year. January 1, we were intermittently staffing Medic 6 as our staffing allowed. We had held so many open FTE positions in 25 that we were down our total count. So we were staffing it intermittently as staffing allowed. We graduated our recruit class in May. I think it was May. And we started staffing Medic 6 full-time. And if that necessitates overtime or callback, we're doing that. And they've been very busy taking a lot of calls. What we're seeing is not only Station 5, but Station 5's response area where they're housed currently, but kind of all over. So it is in service full time and will continue to be throughout the year. And then as far as Station 6, it was presented last night. And Sarah, the acting city manager's recommended budget. Casey, sorry. And more conversations over the coming months.
If I can, for what it's worth too, from an operational standpoint, hearing from the shift commanders, they've talked to me since we've been able to put Medic 6 in service full time. They've said it has made a huge difference, because we have had a lot of points where we would previously be at critical ambulance availability. And not just that benefit, but also because having that unit in the city means we're not pulling a unit from Eudora and a unit from Baldwin up nearly as much as we were in the past. So it is making a big operational difference right now in terms of maintaining coverage throughout the entire county.
Go ahead. I have a couple questions. One is, a number of months ago, we approved some outside ambulance services being available. Has that trickled down into your workload at all yet?
Yeah, absolutely. It's made a big difference. And so when we talked about the decreased ambulance calls, I said 30 to 50% is probably due to the fact that we're no longer using emergency resource ambulances for non-emergency functions, like taking a person back to a nursing home after they've been at the ED, taking a non-emergent transfer to another hospital. Those things are no longer being filled by LDCFM hardly at all. And I'll be honest, the transition to that went a lot more smoothly than I think anybody could have hoped. So we have a very good relationship with them. They are taking off some of the burden. So, reducing calls by, 400 calls so far this year, probably. But that is not, when we look at a 12,000 call total, it's not substantial to the point where we, have it's just keeping our trucks available, I guess.
The other question I had was for county staff. Where do we stand on the agreement with the city of Lawrence?
We've been meeting on a regular basis to update the governance agreement. I think we're looking at some edits to the overall document. I think we're scheduled to meet next week or two to kind of bring some, we asked LDCFM staff to identify if there were some edits they wanted to see to the governance agreement. So I think we're making solid progress on the update. My hope would be after we get through budgets, we can bring something back to both governing bodies and walk you all through it and get feedback.
I was wondering with Station 6 or the Ambulance 6, Medic 6 that we don't yet have a station for, if there's a possibility of spending some time for that ambulance stationed out of Lecompton, it's because there's a high volume in terms of the rural response, there's a high volume there, and the new station location will help with response times to Lecompton. But even like when there are events there and there's a lot of people in town, it's the same distance from town for a medic unit as it would be when they're not having an event.
Yeah, I think there would be some logistical challenges there. I've been in Station 151 quite a bit. They only have 2 bedrooms, and I know CFD is, my understanding, staffing that. But when we internally at the command staff level, when we talked about Medic 6 being an additional unit on duty 24/7, we did identify Station 5 as the location where it will be temporarily be housed, with the understanding that if there was a high demand event potential, that we will relocate that truck. We have had a lot of events downtown lately, and we didn't see the uptick in calls that we were anticipating, but we would have been more than willing to relocate that unit to Station 1 to account for potential increased demand. So we do have the ability internally, and our battalion chiefs, they're empowered to make that decision that if Medic 6 needs to run out of a different station or location for a particular day, they can do that.
And I'm not thinking overnight because there isn't the capacity for that, but just some of the daytime hours, if they're waiting to respond, that they could be waiting to respond from Lecompton instead of just from the middle of Lawrence.
Yeah, those are conversations we could have.
I know we only have a few minutes left, and the best thing for emergency management is when we don't talk about emergency management, right? That means we've been very successful, but I did want to give Robert an opportunity. Well, first, we've got one more World Cup game in Kansas City, right? And just talk a little bit about it, share with us some of what you've learned, in working with these partners and preparing our emergency response. From my perspective, it's been very smooth, and that's, I'm sure, a lot of your work and your team's work. So I just want to give you a chance.
Thank you, Commissioner. We obviously spent a lot of time over the last 1.5 to 2 years planning, and our internal team has done an amazing job in collaborating and bringing our partners together. And we anticipated much worse than what we've seen, much less demand on resources. And that's a good thing. However, we were prepared for the worst, as we always do. But one thing about bringing that unified command structure into play, as we did in years past, is that, again, our relationships continue to build and collaborate, not with just the folks at this table, but NGOs as well, other partners in the community. So the more we do that, the better we'll be prepared, the more input we'll have in our plans, and it's just all a good thing. So, yeah.
Good note to end on. Thank you. Well, we appreciate your time today, and we look forward to seeing you again in the future, as always. And we hope you have a good rest of your day. I'm gonna recess us until I'm gonna give us 5 minutes. So come back. Actually, I'm just gonna round it out to 10:05. We'll be back at 10:05, and our next set of partners can set the table.